I'm now recording this. So I'd like to officially welcome you to our series called Prepare for Victory, Virtual Medical Symposium Series. We created this program because we want to give you, no matter where you are in the world, the opportunity to hear the best information on genetic aortic conditions from our professional advisory board and other leading medical experts on these conditions. We want to thank the Chu and Chen Foundation for making these webinars possible. As you know, tonight's presentation is on lung issues in Marfan syndrome. Let me get this going here. If you have any questions during the presentation, you can put them into the Q&A box that you see on your screen. And Dr. Neptune is going to leave time at the end for us to answer the questions, or for her to answer the questions. Dr. Enid Neptune, who is our speaker, is a member of our professional advisory board. She is an associate professor of medicine at the Johns Hopkins University School of Medicine. Her areas of clinical expertise include chronic obstructive pulmonary disease, critical care medicine, and of course, Marfan syndrome. Dr. Neptune earned her MD from Harvard Medical School. She completed her residency and performed a fellowship in pulmonary and critical care at the University of California, San Francisco. She also performed a fellowship in genetics at Johns Hopkins. You can find her at our annual conference every summer, as she's always there to lead workshops and talk to all of you. So now I would like to stop sharing my screen and give the remote control. Oops, I did that in the wrong order. Guys, this is not my night. And give it the mouse to Dr. Neptune.
Okay.
So do you have that now?
And to start the presentation, I should hit what?
So did you? I just gave you the mouse, but maybe I didn't. Having a not great night. Okay, so I'm giving the mouse to you, so you can control the mouse now. You accept the mouse. There you go.
Okay. Now where do I get my presentation?
Now you hit the share on the bottom. Remember that green button? You hit share, and you select your screen where your presentation is on your computer. Oh, that's mine. So you have to share your screen now.
Okay.
You hit the share button, and then you pick the screen that has your PowerPoint up on your side. You have your PowerPoint up, right?
I need to turn my PowerPoint on or your PowerPoint on?
Your PowerPoint on.
Oh, I see.
Your PowerPoint. You share your screen, which is your PowerPoint. That's
okay. Let me pull my PowerPoint up.
Yeah.
And we will get ready. And
so for the people on the phone, this is our first PowerPoint, our first webinar of the new year. We start in September, so you can see a little bit of rust here. So apologize for that.
And here we go.
There we go. Great.
And I think we got it?
We got it. We're good.
Perfect. First, I want to thank everyone who's joining me with this webinar. And what I want to do is I want to talk about the respiratory disorders that are associated with Marfan syndrome. And I do this because, unfortunately, most physicians are not familiar with some of the pulmonary issues that patients with Marfan syndrome face. And so what I'm going to do tonight is I want to arm you with lots of information that you can take back to your physicians and your caregivers and your family members and make you every bit as well informed as most of the physicians who manage patients with Marfan syndrome. And so I start with this triangle because this slide focuses on the most common symptom that patients with Marfan syndrome develop, and that can possibly involve the lung, and that is shortness of breath. Most of the time, physicians are very, very eager to rule out cardiac issues, and so we're concerned about the valvular heart disease, the rhythm disturbances, and cardiomyopathy, which is really kind of a weakened heart muscle, all of which can occur in Marfan syndrome. And some physicians even kind of address the possibility of deconditioning, which is also quite common in Marfan syndrome and may be somewhat accelerated in persons who have Marfan syndrome who are sedentary compared to the general population. But the issue in the system that is often overlooked is the possibility that the shortness of breath is caused by lung disease. And there are many lung impairments that we see in Marfan syndrome, and these include chest wall deformities, respiratory muscle weakness, enlarged air spaces or blebs and emphysema formation, pneumothorax, sleep apnea syndrome, and also asthma and pulmonary hypertension. But in the interest of time, I'm not going to be able to talk in depth about asthma and pulmonary hypertension, but if you have questions related to those impairments, please submit the questions and I will address them during our question and answer portion. Now you may ask, well, why are there lung problems in Marfan syndrome? And that's because the mutant protein in Marfan syndrome, specifically fibrillin 1, is expressed in the lung. And it's expressed in specific locations that are associated with elastin and connective tissue. And because of this localization, some candidate disorders are seen with Marfan syndrome, which range from emphysema to pneumothorax to sleep apnea and lung musculoskeletal impairment. And that's what we're going to cover tonight. So let's start with restrictive lung disease. About 50% or more of patients with Marfan syndrome have some degree of restriction. And this ranges from relatively mild restriction, which is not something that's of clinical consequence, to pretty significant restriction. And this is usually attributable to musculoskeletal abnormalities of the chest. And effectively what happens is that a person is unable to expand the chest fully. So your lung capacity is limited. So what are the symptoms? The symptoms are typically shortness of breath with exertion or activity. And this can actually progress to shortness of breath at rest. And with further progression, this can lead to low oxygen levels in the blood or cyanosis and even heart strain. On this slide, I depict kind of the basic tests that pulmonologists will obtain for persons who have possible lung issues. And that is spirometry and pulmonary function testing. And this typically occurs in a pulmonary function lab where a person is asked to take a big breath in and breathe out as hard as they can. And in this way, we're able to measure the volume of air that you're able to breathe in and out, and also the rapidity with which you're able to breathe in and out. Now, in order to diagnose restriction, we look at a particular tracing that we generate from these studies. And these are called flow volume loops. And on the left, we see the flow volume loop of a normal person. And you can look on the left side of this. And this is the point at which someone is asked to take a deep breath in and then blow it out as fast as they can. Now, this measurement reflects your lung capacity or your vital capacity. And what I want you to notice is that in a person with restrictive physiology, which we see on the right, that lung capacity is significantly reduced. And that is how we make the diagnosis of restrictive lung disease. Now, what are the causes of restrictive lung disease in persons with Marfan syndrome? These are the three big causes: scoliosis, Pectus deformities, particularly Pectus excavatum, where you get the depression in the middle of the chest, and respiratory muscle weakness, something that's fairly common but is vastly understudied in Marfan syndrome. And we will start with this. So another term for respiratory muscle weakness is the neuromuscular consequences of Marfan syndrome. We know that persons with Marfan syndrome have skeletal muscle weakness. And skeletal muscles involve your limbs, involve your arms, but they also involve your chest muscles that are involved in every breath that you take. And these weakened respiratory muscles can lead to reduced lung capacity and restriction, as we saw before. So how do we make the diagnosis? Well, we make it using those same pulmonary function tests that I talked about, but I also add these two extra tests, and they're called maximal inspiratory and maximal expiratory pressures. And these are diagnostic of respiratory muscle dysfunction. And in all patients that I evaluate with Marfan syndrome and shortness of breath, I obtain these studies. So you may ask, well, what are the treatments if you have respiratory muscle weakness? Well, the critical intervention is pulmonary rehabilitation, which we'll talk about a little later. But if the respiratory muscle weakness is very severe, we may even have to consider ventilation support, which we'll also talk about a little later. Now let's move to pectus abnormalities, which are quite common in Marfan syndrome. And these are typically either pectus excavatum, where you have the depression in the middle of your chest, or the depression can be worse on the right or the left side. And this is probably the most common pectus abnormality we see with Marfan syndrome. However, the abnormality that is most specifically related to Marfan syndrome is actually pectus carinatum, in which the sternum actually projects outward. Now, what is the natural history of pectus abnormalities? Unfortunately, there have been very, very few studies in Marfan syndrome. But what we do know from studies in the non-Marfan population is that the pectus abnormalities are typically benign, but there's a subset of patients who have very severe pectus deformities, especially if they're not in the center, but on one side or the other, that can lead to more significant lung dysfunction. But you get somewhat mixed messages because the evidence or potential for respiratory dysfunction is often the stated reason for pursuit of surgery for pectus abnormalities. However, I will say that cosmetic considerations and whether the affected person feels that the chest wall issue is a problem visually should be a sufficient reason to pursue repair. Now, what are the approaches to repair? What has become kind of the most common procedure is what's called the Nuss procedure, and many of you are familiar with that. And this involves the insertion of a rod beneath the sternum. So it's considered semi-invasive, so you're actually not going into the lung. And this rod is rotated in order to pop the kind of depression out and restore kind of a normal anterior chest wall contour. The advantages of the Nuss procedure are that it's easier than an open surgical procedure, it's shorter, and it has fewer complications. And after more than 20 years of follow-up of this procedure, we know that in most cases, the anatomic result is durable. However, we have very limited lung function data, and we especially have limited lung function data in patients with Marfan syndrome. So you can ask the question of whether correction of a pectus deformity will improve lung function if you have abnormal lung function to begin with. Most of the data suggests that it probably will not. However, there are a couple of considerations that we need to have for persons with Marfan syndrome and pectus abnormalities. The first is that the chest wall defects in Marfan syndrome are often complex. And that means that you can have a pectus deformity that is associated with significant scoliosis. And that combination may very well be associated with more accelerated lung dysfunction. And therefore, an intervention for the scoliosis as well as the pectus might potentially delay or slow down this progression in lung dysfunction. The other consideration is that given all of the other causes of restrictive lung disease in persons with Marfan syndrome, there should be an assessment of functional capacity in addition to obtaining the lung function studies. And this will involve a 6-minute walk test, or in some cases, cardiopulmonary exercise testing. Now we move to scoliosis, which again is very common in Marfan syndrome, and I'm certain that many of the people who are listening now have encountered this particular complication. On this slide, I've listed the factors that are associated with respiratory insufficiency or respiratory failure or breathing problems that are associated specifically with scoliosis. And these include an early age of onset, the association of sleep-related abnormalities or sleep apnea, the association of inspiratory muscle weakness, which we discussed, an underlying etiology that is a syndromic disorder such as Marfan syndrome, and a curvature as reflected in the Cobb angle being very, very significant. On this slide, we see kind of how we actually measure the Cobb angle. And we also see an equation that suggests that we can predict the lung capacity based on the severity of the curvature. But it's not simply the severity of the curvature, it's where the curvature is. Scoliosis that involves the thoracic spine is much more likely to cause lung dysfunction and reduce lung capacity compared to scoliosis that only involves the lumbar spine. And on this table, we see how the progression in the curvature can actually cause lung problems. We see that when the curvature is greater than 40, and clearly when it's greater than 70 degrees, there's a high likelihood that there's associated significant lung dysfunction. And as this curvature progresses, there's an even greater likelihood of symptoms as well as overt respiratory failure and the need for oxygen or even the need for ventilation support. And so it's very important that if there is going to be an intervention for scoliosis, that a pulmonary evaluation is performed. And this should include a full set of pulmonary function tests with a diffusion capacity, which gives us a sense of whether there is accompanying emphysema, as well as those inspiratory pressures that we talked about that can help us assess respiratory muscle function. I typically also obtain what I call sniff fluoroscopy. And that is a way to determine whether the diaphragm, which is another muscle that is critical for respiratory function, is actually working appropriately. Because with severe chest wall defects, the diaphragm is placed in an abnormal position and may actually become stressed and may become weaker. The other thing that I invariably obtain is what we call a 6-minute walk test, where we ask persons to walk for 6 minutes at a normal pace, and we assess how far they're able to walk. And this is really an easy test to establish exercise capacity. And at the same time, we can monitor the oxygen levels in the blood and determine whether the oxygen levels are dropping. And finally, in the setting of very young people, either children, adolescents, or teens, we also order a sleep study because sleep disordered breathing can be very much associated with scoliosis, especially when it develops very early in life. Many of you are familiar with the interventions that are used for scoliosis, and they range from observation to casting and bracing if you have more severe curvatures, and finally the surgical options that I've listed here that range from conventional Harrison rod placement with spinal fusion to the growing rod placement, the vector ribs, the spine staples, and finally, and what's being used more and more, and those are the magnetic rods. But it's important to understand that there are dual goals of intervention. Obviously, you want to prevent further structural deformity, but tethered to that, you want to preserve or improve pulmonary function. And the data for scoliosis interventions are much more persuasive than they are for Pectus interventions. And here I've summarized kind of the causes of restrictive lung disease in persons with Marfan syndrome. And the points are that with Pectus deformities, remember that surgical repair does not correct restriction, and a cosmetic goal is a sufficient reason to pursue repair. For scoliosis, this is typically corrected early, but we know that progressive curvature will develop without correction, and that the pulmonary consequences without correction are significant. And in terms of neuromuscular disease, it's important to diagnose this very early so we can institute a program of pulmonary rehabilitation and consider whether ventilatory support will be needed. Now, this is a listing of some of the pulmonary interventions that we're able to prescribe as pulmonary consultants. And these range from non-invasive positive pressure ventilation, which we use in very severe and significant cases of restrictive lung disease, to pulmonary rehabilitation, which we use typically in the setting of shortness of breath with activity and mild or moderate restriction, supplemental oxygen, and that's what we use if there's evidence of desaturation at rest or with activity. And if the chest wall deformities are so significant that there are areas of the lung that are actually compressed and airways that are compressed, sometimes we have to use bronchodilators or even airway clearance devices. So the take-home message is that with restrictive lung disease in persons with Marfan syndrome, serial pulmonary function tests to follow the progression of restriction are needed. And there should be functional assessments such as 6-minute walk tests to establish the nature of the exercise capacity. Appropriate surgical intervention for scoliosis may prevent or delay further deterioration in lung function, and Pectus repair could reasonably be driven by cosmetic considerations rather than concerns about lung function. Let's move on to pneumothorax. So the first question is, well, what is a pneumothorax? And it's often called lung collapse, and it reflects when the lung detaches from the chest wall. In many persons, the symptoms are primarily the acute onset of chest discomfort or chest pain, and this is often what we see in young patients. However, some persons develop shortness of breath, especially with a very, very significant pneumothorax and even a dry cough. And pneumothorax is diagnosed with some imaging study, either a chest x-ray and or a CT scan. And on this slide, we see precisely what happens with the pneumothorax. We see that there is some type of a wound or some type of a rent or tear in the lung proper. And in the setting of Marfan syndrome, we're usually considering whether there's a bleb or a very enlarged airspace that is traumatized and opens, and air escapes into the pleural space that surrounds the lung, as we see here. Now, what this does is it compresses the lung and causes the lung to collapse. And this is an x-ray of a person with a large pneumothorax, where you can see the gray normal lung in the left side, and on the right, we see a lot of kind of darkness. And this reflects just air because the lung has effectively collapsed. And this is another kind of standing CT scan where we see these blebs in the upper portion of the lungs. And these are structures that are very commonly seen in Marfan syndrome and are very often associated with the development of pneumothorax. So how do we treat pneumothorax? If it's small, hospitalization and supplemental oxygen will be sufficient. However, if the pneumothorax is either moderate or large, a chest tube placement for evacuation may be needed. Now, if the chest tube is placed and despite several days of evacuation and the pneumothorax persists, at that point, a pleurodesis is indicated. And a pleurodesis is really scarring of the pleural surface in order to basically tack down the lung onto the pleura so it will not collapse. Now, this can be done as either a mechanical pleurodesis, where a surgeon actually enters the pleural space and scrapes the pleural surface and then scrapes the lung and tacks them together just like you would a Velcro strip. Or you can do what we call a chemical pleurodesis, where you introduce a fluid that contains a scarring agent, such as talc or such as doxycycline, into the pleural space. With a chemical pleurodesis, the whole of the pleural spaces become scarred. And we're concerned about this for patients with Marfan syndrome because there's not an insubstantial likelihood that the patient may need to have aortic surgery or some other thoracic procedure in the future. And we do not want to consider the challenge of having to dissect through a lot of scarred lung in order to perform an aortic procedure. And that's why mechanical pleurodesis is preferred to chemical. But some of this is dictated by the expertise of the surgeons that are actually doing the procedure. An alternative to a chest tube is what we call a Heimlich valve or a Pleurex that we can actually place and send patients home with and allow the evacuation to occur kind of over a more leisurely time frame. On this slide on the left, we see kind of the blebs that form on the top of the lungs on the left. And you can see that their walls are paper thin and very, very susceptible to rupture. And on the right, we see the ribs. And so this fluoroscopic view allows you to see exactly how you can both scrape the pleural surface and scrape the lungs in order to tether them together. On the right, we see how these blebs can be isolated and removed, and also combined with a surgical or mechanical pleurodesis. So what are the indications for surgery in pneumothorax? And surgery often revolves a removal of the blebs as well as a mechanical pleurodesis. The conventional indications are a massive air leak or suboptimal re-expansion with a chest tube, recurrent pneumothorax, and I typically recommend some type of a pleurodesis procedure at the second pneumothorax in a person with Marfan syndrome, and in selected cases, even with the first event, and we can talk about those. A persistent air leak for several days, bilateral pneumothoraces at the same time, a hemopneumothorax, and that's where there's fluid or blood that enters the pleural space, a tension pneumothorax, and that's where the pneumothorax is so large that the air pushes the heart and the other structures in the chest to one side. And the most controversial indication is that if you have very large blebs or cysts, that should mandate a surgical procedure. And in selective cases, that is advocated, but not in every case. So the take-home message is that first, as we know, pneumothorax is a common manifestation of Marfan syndrome. And if these are recurrent, a pulmonologist should be consulted so there can be some assessment of whether there is respiratory function compromise, and also to do an assessment of what the lung parenchyma looks like overall. And efforts for re-expansion should consider the fact that many patients will ultimately have an aortic procedure, and for that reason, mechanical pleurodesis is preferred. Now let's talk a little about emphysema. So emphysema can be seen with Marfan syndrome, and what it is the loss of alveolar walls. And generally this can be developmental or genetic, or it can be destructive. In the first case, this is what we see with Marfan syndrome, where it seems to be developmental and genetic. But in the case of persons who are smokers, it's what we call destructive. And the manifestation of this is that there's an enlargement of air spaces, and this leads to airway obstruction as well as inflammation, as well as symptoms. And on this slide, we see a schematic of exactly what emphysema looks like. On the right bottom, we see what I call the blackberry structure that's emblematic of a normal kind of alveolar structure, where you get lots of these tiny spheres where you have a thin wall, and oxygen enters the lung, enters the alveoli, and goes into the wall where we have the blood vessels, and that's how we oxygenate all of the critical organs in our body. But in the setting of emphysema, there's either the lack of a formation of all of these walls or destruction of these walls, and therefore we're unable to move oxygen very efficiently in the bloodstream, and the lung function is compromised. And that is why persons with emphysema develop shortness of breath and develop cough and develop respiratory symptoms. And so the symptoms, as we see here, are the shortness of breath with activity. You can also get bouts of bronchitis because your airway clearance is also compromised with emphysema. And sometimes if it's very advanced, you can actually get very low blood oxygen. How do we make the diagnosis? We typically require some imaging study, either a chest X-ray or a chest CT scan, especially a high resolution scan. Pulmonary function tests that show obstruction instead of restriction, and arterial blood gases. And how is emphysema treated? Well, we use a battery of interventions that include bronchodilators, inhaled steroids, and oxygen if necessary. We also recommend aggressive treatment of infections. And so if you have emphysema, you don't tolerate kind of bronchitic symptoms for a few days and just see if they get better. Your physician should order antibiotics very quickly so that there is not persistent inflammation and irritation of the lungs. And this, in the setting of very advanced emphysema, surgical interventions may be necessary. And so the take-home message is that emphysema is probably a sequela of disturbances in lung development in Marfan patients. We see this especially in persons with neonatal Marfan syndrome. And in that case, this can lead to very significant disability as they age. And symptoms of shortness of breath, recurrent bronchitis, pneumothorax should always prompt an evaluation by a lung specialist in order to make sure that the appropriate therapies are implemented. And we'll end on sleep apnea. And the definition of sleep apnea is that this is an intermittent cessation of airflow at the nose and the mouth during sleep. And it affects a significant number of non-Marfan persons. And we know that it has an even higher prevalence in Marfan syndrome, which I'll show you shortly. It's the cause of excessive daytime sleepiness, although sleepiness may vary in patients who have Marfan syndrome. And it can either be obstructive, where the upper airway obstruction prevents the ability to take a deep breath, or it can be central, where your central nervous system doesn't give you the stimulus to take a deep breath. Now, this slide depicts kind of what the physiologic consequences of sleep apnea are in patients with Marfan syndrome. And this is specifically obstructive sleep apnea. So when you take a big breath, the breath comes through the nose or through the mouth. However, with obstructive sleep apnea, the upper palate actually drops back because of floppy soft tissue, and the tongue drops back. So what you have is an obstruction to nasal airflow, as well as an obstruction to airflow through the mouth. And sleep apnea can be potentially life-threatening because it's associated with motor vehicle accidents, a battery of cardiac complications, including aortic issues, strokes, and reduced productivity and reduced quality of life. Now, studies from our group, as well as others, have shown a very high prevalence of sleep apnea in persons with Marfan syndrome, particularly obstructive sleep apnea. And we think that's because of these battery of impairments that accompany Marfan syndrome, including craniofacial issues with changes in the mandibular structure or the jaw structure and the teeth, floppy upper airways, which is similar to floppiness in other structures in Marfan syndrome, as well as chest wall deformities that I talked about earlier. And this combination of these impairments lead to a much higher risk of obstructive sleep apnea. Now, this is what we're particularly concerned about. We think that there's a relationship between risk of progressive aortic enlargement and the diagnosis of obstructive sleep apnea in patients with Marfan syndrome. And that is because we know that these obstructive events lead to exaggerated changes in the intrathoracic pressure. And this is kind of experienced by all of the structures in the chest, including the aorta, which is quite vulnerable to begin with. We also know that there's an increased risk of high blood pressure, which is also a stress to the aorta. And we also know that there are other stresses, including low oxygen levels, inflammation, and oxidative stress. And this battery of insults, we're concerned about leading to a progression in aortic enlargement and ultimately to an increased risk of aortic rupture and aortic dissection. And so we feel that the early diagnosis of sleep apnea in the Marfan population could potentially prevent the progression of aortic enlargement in a selected population. And that is why we are doing a study at Johns Hopkins looking at sleep apnea in persons with Marfan syndrome. Now, how do you make the diagnosis? You typically make the diagnosis with a sleep study, and a sleep study in a clinic or in a hospital that will give us information about the brain activity, the eye movements, muscle activity, airflow, and oxygen levels, as well as awakenings, as well as the time it takes for you to fall asleep. In our lab, we also do a measurement of upper airway resistance. And with this battery of information, we're able to obtain a very detailed information stream of what is happening while you sleep. Now, if we do make a diagnosis of sleep apnea, nasal CPAP is often the conventional intervention. And this may or may not be accompanied by supplemental oxygen. And in patients with Marfan syndrome, I find that sometimes it's very difficult to find a mask that fits properly. And what I suggest is that if you haven't tried at least 5 masks, you haven't asked for an appropriate rigor by your sleep specialist in obtaining a mask that works. So do not feel uncomfortable by asking for another mask or another mask or another mask until you find one that's comfortable. If you have only mild sleep apnea, there's a possibility that you can use a mandibular advancement device for an oral appliance. In Marfan syndrome, weight loss is not typically the intervention of choice, and drugs are not typically helpful. And in very, very rare occasions is surgery indicated. And this shows what happens with nasal CPAP. So basically air is delivered at a certain pressure that effectively stents the upper airway open and prevents the collapse that causes all of the sequelae that we're concerned about. And these are some of the devices that are used. They range from apnea pillows to nasal masks to a full face mask or even a dental device. So the take-home message here is that sleep apnea is underdiagnosed in Marfan syndrome, that all adult patients with Marfan syndrome should be considered for screening. And hopefully with our study that is totally open, and we hope you will investigate on our Marfan Foundation site as well as on the Facebook site, we'll determine kind of how these sleep disturbances relate to aortic health. And we'll be able to come up with more useful tools in the Marfan population to make the diagnosis at the earliest possible point. So on this note, I will stop the presentation and I will invite questions and I will answer as many as I possibly can.
Okay, so I'm going to take the screen back from you and let's see here. Let's get down to, before we do the questions, I just want to take 1 second because you did mention the study, and you know, it's really important that that we get a lot of information about people with Marfan syndrome, so researchers can get the information they need to study issues like sleep and Marfan, things that have not been studied before. So we have the Marfan and Related Conditions International Patient Registry. We work with Backpack Health on that. One thing it does for all of you is it helps you compile all your health information in one place. It's secure, and it's a way it comes in 6 languages, and it has functionality that allows you to share certain information with people that you want to share it with, like the school nurse, or if grandparents are taking kids on vacation, or if you were to share information easily with a new doctor or with in an emergency situation. The other thing is that, as I said, it collects information for research, and you have an opportunity to consent and opt in, and then your information is de-identified and aggregated with information from other people in the registry. So you control who gets what. It's easy to join. It's free. Here is a couple more pictures about what it looks like. And there's a link, and I will put that link in the follow-up email so that you all see how you can get involved in the registry and how you can take advantage of this opportunity to compile your health information. And so now what we're going to do is we are going to go to the question and answer box. So if you put your questions in the chat box, go ahead and put them in the question and answer box. And let's see. One question, and we talked about this actually before this webinar even started, is I can't even say this, bronchiectasis. What do we need to know about that? This person's pulmonologist says it's common in Marfan syndrome.
Okay. Should I hit the Q&A button to see the...
No. Just you can just answer the questions that I'm posing to you. That would be the way to do that.
Okay. Bronchiectasis has been seen with Marfan syndrome. It's not one of the more common complications of Marfan syndrome. But again, I've seen it, and along with some of the other, what I call parenchymal manifestations, and those are the manifestations within the lung proper, I recommend very aggressive treatment of this. And I think that that a full respiratory assessment should be conducted, and definitely a referral to a pulmonary specialist should occur.
Great. How about somebody with Marfan syndrome playing a wind instrument, and whether it's recreationally or this person's actually asking about professionally, like 6 hours a day? Is that risky? Do you recommend it, not recommend it?
That's a question that often comes up, and it frequently comes up in the context of somebody who has a history of blebs or a history of a pneumothorax, and whether that can actually trigger another event. And the fact is, we never had the data that shows that persons with kind of a history of a pneumothorax or history of blebs have an increased risk of developing a new event if they play a wind instrument. So I can't give you kind of objective evidence that that's a concern. I would say that if someone's had a recent pneumothorax, I tend to discourage any types of what we call maneuvers where you're increasing kind of intrathoracic pressure for at least the first 3 months after a pneumothorax. But beyond that, I have no data to discourage you from pursuing your musical gifts. Great.
Okay, so you talked about the NUS procedure. Somebody is asking if it impairs the effectiveness of CPR. I mean, I don't know how common that is, but
it's a very, very good question. And I think that there's a consensus that CPR is usually done aggressively enough that it should not be an incredible problem. However, I do think it's important to notify kind of the emergency team or the physicians involved that there is a rod in place, and that is because these rods can potentially migrate. And with aggressive CPR, what you don't want is to have the rod migrate into a structure that's critical. So I think the information should be provided, but effective CPR should still be able to occur.
Okay, great, thank you. Somebody here has a child with a condition related to Marfan called Stickler syndrome, type 1. And she's asking specifically about the croup and I guess other pulmonary problems. Are there overlaps with Stickler's with the pulmonary issues of Marfan?
Yeah, well, with Stickler syndrome, there can be kind of an increased risk of the condition that actually the first questioner kind of mentioned, and that's bronchiectasis. And what I didn't do is I didn't define the bronchiectasis. That's actually inflammation of the proximal airways, where you don't just get kind of the kind of obstruction that we see with asthma. You can actually get destruction of the kind of actual wall. And so the walls become kind of big and floppy. And then you have associated chronic inflammation, a chronic productive cough, and often you need to be on a regular schedule of antibiotics. And so I, again, would stress that in the setting of bronchiectasis with Stickler syndrome, you need to be under the care of a pulmonologist who's able to follow the condition, treat the infections very early, and try to preserve as much lung function as possible.
Great, thank you. Here's somebody whose nephew had a surgical repair of his pectus carinatum at 5 and again at 18 without success. And so they're painful and well, it says his chest remains severely caved in, but carinatum is actually protruding. So I'm not sure if this person has an excavatum or carinatum. But so either way though, can you just repeat again, when is it a cosmetic concern and when is it something that needs to be corrected for, for physical reasons?
Okay, the physiologic kind of reasons are very uncommon, but I would say that if there's evidence of significant lung impairment that is directly related to the compression of the chest, and that's usually attached to pectus excavatum as opposed to carinatum. Right. But in certain cases of carinatum, if there is an asymmetric distortion of the chest wall, you can actually get physiologic impairment from that. So in that case, if it looks like there's progression and if the severity of the lung dysfunction is significant, then a surgical intervention is clearly indicated. And the absence of that, it's a matter of whether the patient finds the cosmetic result acceptable. There are many kids, especially teenagers, who are perfectly fine with a pectus deformity. And their parents are more concerned than the actual kind of teenager is. No, the other point I wanted to bring up, Eileen, is that if there's been a correction before the age of 6, and especially if there's been a surgical correction, and the correction for pectus carinatum is usually an open surgical procedure. If that's taken place, there's a higher risk that there's lung function issues because of the early surgery. So this person should definitely be under the care and management of a pulmonary specialist.
And I just wanted to add, if anybody has teenagers or kids or even they themselves have issues with the cosmetic concerns of a pectus deformity, I would strongly urge you come to our annual conference in the summer and head to the pool where everybody else with Marfan is there. And people find it very comfortable being there. Everybody's got the same kind of issues, and you could feel free and feel good about yourself and not even think twice about it. So we see that happen every summer at our conference. So. And you can also meet Dr. Neptune there. It's a plug for our conference. What about a correlation between COPD and Marfan syndrome?
The correlation that we found has more to do with some of the problems with the lung architecture and the fact that we see these large blebs and we see emphysema, especially in our neonatal Marfan patients. And what we can use is some of the information we have on treating patients who have garden variety emphysema, who I see often also. And so we are very aggressive with using bronchodilators, with using anti-inflammatory medications, with following their imaging studies, and following their lung function. And so we know that there's a high likelihood of progression in lung dysfunction in patients who have the emphysema and these blebs. And so we tend to be very aggressive in the management of these patients, and I certainly am with my patients. The other kind of consideration are those who have asthma, which is a form of obstructive lung disease. And this involves also patients who have Loeys-Dietz syndrome. And what I typically recommend is that they use bronchodilators, but try not to use kind of beta agonists or albuterol or those types of drugs because they oppose the effects of beta blockers. And so I don't like to have that competition going on in my patients. So I advocate that they use what we call anticholinergics like ipratropium. And that's what virtually all of my Marfan patients who have asthma or emphysema are on.
Great, thank you. Here's a question from somebody who had chemical pleurodesis to adhere the left lung to the diaphragm as their lung came off the diaphragm. They want to know if that will cause problems in aortic surgery in the future.
Did they say what kind of pleurodesis they had?
It just says chemical pleurodesis.
Oh, okay. It, it could make the dissection a little more difficult. What I would do is make sure that your surgeon is very much aware that a chemical pleurodesis was performed. Sometimes that's obvious from the imaging, but sometimes it's not. And so as long as the surgeon is very well prepared for the degree of scarring that he or she may encounter, it can be addressed. But again, I stress that if there is a choice between mechanical or chemical, I typically recommend mechanical.
Okay, thank you. You mentioned on the slide for the treatments of emphysema some experimental things like retinoic acid and antioxidants. Could you just say a couple words about each of those and how they can help?
Yeah, a lot of the data for those interventions have been obtained in patients who have more garden variety emphysema and in smaller studies. But we have extensive data, as you can imagine, in our mouse models of Marfan syndrome. And my belief is that the agents that work well in terms of stabilizing or regenerating kind of lung tissue in our mouse models are going to be potential candidates that we can use in patients with extensive emphysema or blebs. And it's those kind of studies that we're pursuing right now at Johns Hopkins. And you guys will be the first to know with what we find with our experiments and also what we find in our clinical studies.
Great, thank you. Somebody says that they were diagnosed with sleep apnea by sleep studies, but he thinks it might be caused, I think it might have been caused by acid reflux. Any way to tell the difference between that and Marfan causes?
Well,
does that make sense?
Oh yeah.
Okay.
It's relatively uncommon for acid reflux to cause sleep apnea. It's not uncommon for acid reflux to cause asthma or reactive airway disease. So if you've been given a diagnosis of sleep apnea, I would focus on some of the Marfan related causes that I discussed in my presentation and not the possibility that it's related to acid reflux. And I'm thrilled that you actually had a sleep study and you had it diagnosed, and now you're charged with making sure that it's treated effectively.
Yeah, that is definitely the first step. Some people are hesitant to do it, but that's important to do. Can you talk for a minute about pleurisy as it relates to pneumothorax and Marfan syndrome?
Yeah, pleurisy, and if of those of you who don't know what pleurisy is, that's actually chest pain that occurs when you take a big breath in or when you cough. And some of you have experienced this when you have a pneumonia or sometimes when you have kind of a viral pneumonia. But in Marfan syndrome, the number one thing that we need to think about is whether it's associated with the pneumothorax. And so if you're developing pleuritic chest pain and you've not had this before, then you need to have an evaluation with a chest x-ray and ideally a chest CT scan to see if you in fact have a pneumothorax. But I should say that there are patients that I see who have had pneumothoraces with Marfan syndrome, and they continue to have some degree of chest discomfort for months or for years. But they're able to distinguish kind of their chronic low-grade chest discomfort from some new process. And that is the kind of discernment that many patients with Marfan syndrome have to make with a variety of different kinds of chest pains or chest discomforts.
Okay, here's something that we haven't talked about, and I cannot say the entire name of this, but what this person is asking about is something called LAM, which is thin-walled cysts throughout both lungs. Very long word, and he or she wants to know if you see it in Marfan patients. They say they have it, but don't have any. They don't have any of the symptoms of LAM, and they're wondering if Marfan syndrome could cause the thin-walled cysts.
Okay. The LAM is, the long word is lympholeiomatosis. So
yes. I know, I see it here, but I wasn't going to try it.
It's also a genetic disorder, and it does result in kind of large cysts in the lungs. It's quite different from Marfan syndrome, but I would say that both patients who have LAM as well as patients who have Marfan syndrome have a much higher risk of pneumothorax. And so the differential of a young person, and in the case of LAM, a woman who is seen for pneumothorax, has to include both Marfan syndrome as well as LAM.
Okay, great. We're going to be handling the rest of these questions separately from this webinar because we do want to get your questions answered, but we are getting to the end here. So I want to just let you know that we do have a couple of more webinars coming up after this. Next up in a couple of months will be Dr. Shireen Shalab, who is going to be talking about the management of dissections and aneurysm in VEDS. And then Dr. Sylvia Fraser-Bowers is going to talk about dental concerns in Marfan and related conditions. Having trouble with these things here tonight. So on our website, you can see right here when you go to marfan.org and then patients and families and then click on virtual medical symposiums. And that's where you could be able to find all the recordings and also to register for additional webinars. I heard a lot of you do have kids who are on this webinar tonight. If you have any children who are going to be in the hospital, we have a program where we provide baskets and goodies to help them through and provide support from the foundation. That's the Sidney Lerman Pediatric Hospitality Program, and we are happy to send a box of goodies to you through this fabulous family program, the Lermans. That is on our website too. And we have lots of upcoming events. So I know a lot of you are from all over the world on this webinar, but if you happen to be in any of these areas in the upcoming months, you see we have walks scheduled. They're walk optional. It's more about getting together with community, meeting people who are just like you, having a great community feeling. Of course, raising funds as well, but it's really about getting together. And so coming up the rest of this year, we have St. Louis, Orlando, Sacramento, and you see the rest of them there. We have some regional symposiums coming up, so you can hear great talks like this one we had tonight, plus hear from other specialists. And the next one is in Minneapolis in a couple of weeks, so we hope to see you all there if you're in that area. There are ways for you to get involved in our new Volunteer for Victory program, and all of this is on our website. And finally, we were so happy to have Dr. Neptune here tonight. We thank her for her time and sharing all of her knowledge with us tonight. There's so much more in this area. The best thing to do is submit the questions through our Help and Resource Center. Jan Lynch is our nurse who runs that. And best thing really to do is to go to marfan.org and look for Ask a Question. I put her contact information on there, but because I like to share that. And there's Jan's smiling face. She's always happy to talk to you guys. But ask a question through the website. Sometimes she does travel on business, so if goes to different conferences. So if she doesn't respond quickly, give her a chance. She definitely is there for all of you. So I want to thank you all for being here tonight. We had over 100 people on live. This was fantastic. Dr. Neptune, thank you for your time, and we will get everybody the sleep study link so they can get involved with that. Do you have any last words that you'd like to say?
Just pursue kind of really, really good lung health, and you can contact me anytime through the Marfan Foundation site, and I want you all to have wonderfully healthy lungs.
Perfect way to end. Thank you all so much. Have a great night.